A very good morning to our honorable and respected Emeritus Chairperson, Sir, Dr. M.L. Swankar, Sir, our distinguished guest, Dr. Lucky Jain, Sir, our Vice Chancellor, Dr. Achal Gulati, Sir, our Pro Vice Chancellor, esteemed faculty members, dear colleagues and friends. Today, it gives me an immense pleasure to welcome you all in this CCR as this has been conducted on the occasion of our Emergency Medicine Day, the 27th May. It was just a coincidence that it has happened on this day. Emergency medicine, as we all know, it stands as the forefront of healthcare in any system where timely decisions, coordinated teamwork, and evidence-based practices influence the overall outcome of the patient. Before I begin with the academic deliberations, let us just briefly walk through the journey of emergency medicine in this institute. We started in the year 2017 with the baby steps with the vision to have a vibrant emergency care system in our hospital. And to add on this, a major milestone was added in the year 2020 with the first batch of 2 emergency medicine residents was given to us by the NMC. This was the first in the state of Rajasthan, and to my knowledge, it was the first in North India apart from the AIIMS Delhi Institute. So we were the first to begin with the emergency medicine department in Rajasthan and in North India also, sir. Today, along with me, 7 dedicated faculty members of the emergency medicine with 9 PG residents and around 35 nursing staff with helping hands are continuously giving the emergency medical services to the patients in our department. Our alumni, 3 batches have been passed. 2 of them are pursuing DM in critical care from elite institutes, and they are a pride for the institute and for the department. So about the department, at present the department is catering around 70 to 80 emergency patients every day, ranging from the neonatal emergencies to geriatric population, and we are handling all kinds of traumas, all kinds of neurological, cardiac, different emergencies, onco emergencies every day. This burden is increased, especially during the tropical fever season from July to November to around 120 patients per day. We are stabilizing the patients, resuscitating them, and then we are admitting across about 900 to 950 admissions every month throughout the year in various departments after the initial stabilization. This tells us that the importance of emergency medicine department in a healthcare system where they are acutely managing the critically ill patients in time. Regarding the infrastructure and facilities, I would say it is an honor, it is a pleasure to work in this institute because we have been provided with the state-of-art resources to us to deal with all kinds of emergencies. We have a dedicated 40-bedded units in the emergency department, starting with the triage area, the resuscitation bay, the trauma bay, the dedicated 6-bedded emergency ICU, the emergency operation theater, a separate emergency bed for the emergencies, and apart from this, the infrastructure also has a dedicated imaging area. We have, sir, our own X-ray unit, CT scan, MRI in our emergency zone only for the patients. We do not have to send them to distant areas of the hospital for these investigations because time is of essence for our patients. Apart from this, we have a dedicated point-of-care ultrasonography in our machine in our department, a portable X-ray unit, a point-of-care laboratory which is telling us about the ABGs, the cardiac panels, the INRs, the routine investigations, the blood tests, the ECG, everything there only in our unit. The procedures which we have performed in the last year, which are very important for the emergency medicine to learn, there are around, including the airway management with the advanced techniques, around 930 patients were intubated last year with different kinds of patients coming with trauma, difficult airways. Then we have performed the CPR, which is called the cardiopulmonary resuscitation on the patients who come on the verge of no pulse, no respiration. And around 138 patients were performed CPR. The regional blocks we are giving to the patients, the arterial advanced lines, like central lines and arterial lines, the cardioversion which is required for the cardiac emergencies where they have unstable brady or tachycardias, then the placement of the this intracostal drainage tubes, the ICDs, the defibrillation, and apart from this, the more important is the thrombolysis in the acute window period, which has about 26 in the last 1 year. The list is quite exhaustive. It is perhaps never ending for us because we keep on performing the procedures in time. About the achievements and highlights, I would like to emphasize on this because this is a significant achievement of our department of consistent attainment of the return of spontaneous circulation after the CPR, which is increased from 2025 to 2026 year to 76%, and around 11% of them, they are about survival to discharge from this hospital. Most of them are from the cardiac emergencies or the people from kidney diseases, because they come with the hyperkalemic arrest or they come with the hypoxia or high hydrogen ions like severe acidosis. So we have been able to give them life back with survival to discharge after the attainment of ROSC also. Academic activities to impart the comprehensive knowledge to our students and to provide with the practical skills. We are continuously conducting the seminars, bedside clinics, our journal clubs, the integrated teaching from different departments. The guest lectures are being performed, and above all these, there is a simulation-based training also. Right now, we are giving to our students because they cannot handle airway or any line placement directly on the patients. They have to be taught in the labs, skill labs, which we have a dedicated lab in our institute, sir. To add on to this, I am proud to tell you that this organized under our emergency department, we were able to conduct the first ever the CME cum workshop for the emergency and other residents who were willing to attend, and in the month of December, and it was well attended by 50 students. 25 were the PG students and 25 were undergraduates and interns. So they were giving hands-on training from basic to advanced airway with simulation. So for that we brought the pig's trachea to teach them to how to do the surgical cricotherapy in emergencies. So that we got a very positive feedback, and we continue to with this culture in near future also to train our students with simulation-based training. Other than that, we have our certain community responsibilities also, and for that we are performing the outreach activities by training the basic life support, the trauma care, and handling of the snake bite patients to the nearby societies, especially the students of the private institutes which are running around our hospitals, and to the people who are working in the industrial area nearby our institute. Sorry. Now, the academic achievements are a matter of great pride for our department. When my third year student, Dr. Avniendra Bharadwaja, he got first prize in the best paper category at the international conference being held in Pondicherry from the emergency department. So, and apart from this, my faculty members are also presenting at different platforms in the different institutes and the conferences as a part on the panel discussion or the teaching or workshops. Two of my faculty members, they have also cleared MRCM, that is medical, Royal College of Emergency Medicine, MRCM, which is considered a prestigious achievement for the emergency medicine people. With these words, I once again welcome you all for this CCR and wish you a very high, enriching and productive session. I call upon stage Dr. Rupam Joshi, first year resident of my department, to continue with the academic.
Thank you, ma'am. Good morning, everyone. Today I, Dr. Rupam from the Department of Emergency Medicine, over the next few minutes, will take you through our case, Breathing Through Chaos, its clinical presentation and the initial assessment. A patient, a 43-year-old male resident of Jalapura, Jaipur, presented to us in the emergency with difficulty in breathing since last 10 days. However, in the last 24 hours, the situation dramatically worsened as the patient developed bleeding from an ulcerative lesion present over the left side of his face. On arrival, he appeared distressed with a heart rate of 128 beats per minute, BP of 128 by 80 mmHg, respiratory rate of 33 breaths per minute, and a saturation of 81% on room air.
So this ulcerative lesion was there for how long? This was not a presenting complaint?
Sir, the ulcerative lesion has been since long because the patient was a known case of squamous cell carcinoma of the left buccal mucosa. I'll be telling about it briefly. The saturation was 81% on room air. At this point, we immediately triaged him as level 1 category red. A brief history from his brother revealed the difficulty in breathing was insidious in onset and gradually progressive, which worsened on lying down, now associated with a loud, noisy breathing. Importantly, he was a post-operative case of recurrent squamous cell carcinoma of the left buccal mucosa who had completed his chemotherapy and radiotherapy. As per the emergency protocols, a primary survey was done. The airway assessment was alarming as the patient had stridor at rest and drooling of blood-thin saliva, both red flags indicating a threatened airway. The patient had a labored breathing with saturation of 81% on room air and he was tachypneic. At this point, we immediately supplemented him with 10 liters of oxygen via face mask. On bilateral auscultation, rhonchi were present and air entry was reduced. We nebulized him with Duolin and Budecort. He had tachycardia and his BP was within normal limits in the sitting position. 2 white bore cannulas were secured and he was started on IV maintenance fluid. Despite the respiratory distress, our patient was conscious oriented following verbal commands with no neurological deficits. As the picture reveals the partial complexity of our case, our patient had a severely distorted anatomy with a large orocutaneous defect and extensive soft tissue loss along with active oozing from the lesion. A quick ECG showed sinus tachycardia and ABG revealed type 2 respiratory failure. At this point, while airway interventions were being thought upon, a secondary survey was done. Our patient had a long and complex oncological journey. Back in 2017, he was operated for the squamous cell carcinoma. He underwent a wide local excision along with left hemimandibulectomy and a modified neck dissection. Unfortunately, a local recurrence occurred in 2024 and he underwent wide local excision along with subtotal maxillectomy. Post-surgery, the biopsy confirmed the recurrence and he underwent 6 chemotherapy cycles and 30 radiotherapy cycles. At this point, I would like to emphasize, during the course of hospital stay, during both the surgeries, a tracheostomy was done. Adding to his misery, a flap dehiscence occurred in July 2025, following which he underwent adjuvant chemotherapy. In view of dysphagia and the extent of the disease, a feeding jejunostomy was done in December 2025. Our patient was known hypertensive since last 5 years on tablet.
So, few comments related to oncology, maybe not relevant to your, very quickly. So, 6 cycles of chemoradiotherapy, this is chemotherapy given for radiation sensitization, and this is known as CTRT or chemotherapy plus radiotherapy. And you will never have adjuvant chemotherapy in that situation. It's probably palliative chemotherapy. Okay?
Our patient was a known hypertensive since last 5 years on tablet telmisartan and cilnidipine with poor drug compliance. He had a significant personal history of tobacco chewing, which remains an important etiological factor in his disease progression. He had no known drug allergies. On general physical examination, our patient was conscious with significant pallor. His vitals were similar to that of on arrival, except I would like to emphasize this is saturation increased from 81% to 84%, responding only slightly to the 10 liters of oxygen supplementation. On respiratory system examination, stridor and bilateral rhonchi were present. No other abnormalities were found in any other system. I would now like to summarize a case, a 43-year-old male post-operative case of recurrent squamous cell carcinoma of the left buccal mucosa, presenting with stridor, progressive respiratory distress and bleeding from the lesion. And from the primary survey, it's very clear that a patient had anatomically and physiologically challenged airway. Coming to the critical question, what do we even do with the challenge in hand? At this point, I would like to call upon Dr. Akshita from the Department of Anatomy to briefly discuss the anatomy of the normal airway.
Thank you, Dr. Rupam. Good morning to everybody. I'll be explaining the anatomy as seen in the mid-sagittal section of the head and neck. We can see it will be divided into nasal cavity, oral cavity and pharynx, which will be extending from the base of the skull till the lower border of cricoid cartilage or the C6 vertebral level. First coming to the external nose. External nose being frameworked by bones and cartilages. The bones being there are the nasal bone, the frontal process of maxilla, and in the inferior surface the two palatine process of maxilla, and the cartilages formed are lateral alar cartilages and inferior septal cartilage. The nasal cavity, as we see here, is the lateral nasal septum, which contains the three turbinates, superior, middle and inferior turbinate, respectively having superior, middle and inferior meatus. The nasal cavity communicating with the nasopharynx through posterior nasal aperture and continuing into the oropharynx. The nasal cavity divided from the oral cavity by anterior 2/3 with the hard palate, which is formed by two palatine process of maxilla, and 1/3 by the soft palate continuing into the uvula. The oral cavity majorly formed by the tongue and also has one anterior and one posterior pillar, which is the palatoglossus pillar, and the other is palatopharyngeus pillar, having a tonsillar fossa in between and medially continuing to the uvula. The laryngeal cavity divided into three parts: the supraglottic, the glottic and the infraglottic region. The supraglottic region having the epiglottis and the vestibule vocal fold. Then we have the true vocal fold, and in the infraglottic part extending till the starting of carina. Here we can appreciate the lost anatomy in our patient. The loss of the nasal turbinates and the nasal bone and left side maxilla, and also in the left side mandibulectomy done, so loss of mandible. Now I would like to call Dr. Kanupriya to continue with the case.
Good morning everyone. Thank you Dr. Akshita. That was as the anatomy should be. And let's talk about what happens when none of that looks like and how we manage it in emergency airways. As you can see, we have three tools in our emergency department. First, rapid sequence intubation. Second, supraglottic airway devices. And third, emergency front of neck access. Let's start with our first choice. Rapid sequence intubation, that is the cornerstone of emergency medicine. RSI is simultaneous and rapid administration of sedative and paralytic agent to improve first pass success and prevent aspiration. This brings us to how we evaluated whether our patient is a safe candidate for RSI and was the laryngoscopy difficult. To formally anticipate difficult direct laryngoscopy, we need rapid and reliable screening for predicting the airway. We look externally to examine for the signs of difficult intubation such as facial disfigurement, bearded face or any external masses. We evaluate 3-3-2 rule to assess the patient's airway geometry. For laryngoscopy and tube placement, we need appropriate mouth opening, neck movement and thyromental distance. So this is the effective summary of it. In obstruction and obesity, if there is presence of any intrinsic or extrinsic masses, and if the neck is in full mobility or not. So let's apply this to our patient. While examining the external features, there were presence of gross facial disfigurement of the midface and the perioral anatomy with oozing of blood-tinged saliva and tissue necrosis. We couldn't evaluate 3-3-2 rule. Now for this part, brace yourselves. This is what impending obstruction sounds like. There was presence of inspiratory stridor for which we suspected tracheal stenosis, probably due to previous tracheostomies done. The neck was in fixed flexion deformity and with no extension, patient couldn't be positioned for direct laryngoscopy. So RSI was off the table as the first choice. Can we at least rescue this airway with supraglottic airway devices if RSI fails? Supraglottic airway devices such as LMA and iGel are brilliant rescue devices, but in our patient, the upper airway anatomy is distorted, and without it, we couldn't even insert the device inside the oral cavity. So even supraglottic airway devices was predicted to fail. That means we are heading towards ephona, that is cricothyrotomy. As the image is self-explanatory, even our last line of defense, emergency front of neck axis, carries the risk of failure. But why is it so? First, the anatomical landmarks were lost. Second, the neck was in flexion deformity. And third, patient was in sitting position. But we still kept it as a reserve. Now, with the feared triple, predicted difficult direct laryngoscopy, predicted failed supraglottic airway devices, and predicted difficult ephona, all our three plans compromised. This is a true lost airway. So where does this leave us? How do we deal with this lost airway? The answer is not brute force. The answer is not blind hope. The answer is, whenever we get puzzled, we call our seniors. I call upon Dr. Avniendra to carry the presentation forward.
Thank you, Dr. Kanupriya. At this moment, we have already established that this was the kind of airway in which the speed would kill. No paralysis, no heroic laryngoscopy, no force. So, the solution was far more difficult. We would intubate the patient awake. Every breath preserved, every movement controlled. This was no longer an routine emergency airway management. Awake fiber optic intubation, it is not the first choice because it requires extensive patient cooperation. It is highly time consuming and demands a high technical level of skill set. In this, the patient is kept awake with no neuromuscular blockade. Only mild sedative and topical anesthesia helps facilitate the procedure. Coming to our patient and the procedure, first of all, the patient was extensively educated. Every step was explained to him in great detail, so as to have maximum coordination from him. After that, an informed written consent was taken, and then the fiber optic bronchoscope trolley was prepared. I must highlight that this state-of-the-art modality has been made available to us by the management, and for that we remain sincerely grateful. As the last resort, ephona tray was also kept at handy. The patient was placed in a sitting position, again to reiterate the fact that he had a fixed flexion deformity of the neck, and putting him in supine position was causing him even more distress, leaving us no choice but the sitting position, and the operator was standing in front of the patient. Pre-medication was given, and then it was time to silence the airway for the maximum ease of the patient. And because airway nerve blocks work only when anatomy is respected, I again invite Dr. Akshita to briefly discuss the nerve supply relevant to our case.
Thank you, Dr. Avniendra. With the help of the obtained specimen from the Department of Anatomy of our college, I'll be explaining the nerve supply and where we can find these nerves. So to give an orientation of the specimen, this is the nasal cavity, this is the oral cavity, and this is the hypopharynx coming through the vocal folds. First, the three major general sensory nerve supply are the trigeminal nerve, the glossopharyngeal nerve, and the vagus nerve. Anterior ethmoidal nerve and greater palatine nerve coming from the trigeminal nerve supplies the roof of the nasal cavity and to the sphenopalatine ganglion, which is behind the middle turbinate. The glossopharyngeal nerve found posterior to supplying to posterior 1/3 of the tongue and the mucosa of the pharynx, and then we have internal laryngeal nerve which supplies above the vocal folds, and the recurrent laryngeal nerve which supplies below the vocal folds coming from the vagus nerve. Here we can appreciate where we find the glossopharyngeal nerve, which is between the two pillars, the anterior and the posterior pillar in the tonsillar fossa bed. To continue with the case, I'll call Dr. Avniendra.
Thank you, Dr. Akshita. Now that we finally know where all the nerves are hiding, let's go ahead and politely convince them to stop feeling things. There are three areas of interest from where the ET tube would be passing. The nasal cavity and the nasopharynx supplied by the trigeminal nerve, oral cavity and the oropharynx supplied by the glossopharyngeal nerve, the larynx and the trachea supplied by the vagus nerve. In the nasal cavity, the two target nerves were the anterior ethmoidal nerve and the greater palatine nerve. For anterior ethmoidal nerve, long cotton-tipped applicator soaked with lignocaine was passed parallel to the dorsum surface of the nose. And for the greater palatine nerve, another applicator with soaked lignocaine was passed just anterior to the middle turbinate. For the glossopharyngeal nerve, which is found in the palatoglossal arch, it was relatively identified in our patient and local anesthesia spray was given. Till the time the local anesthetic started doing its job, we prepared and connected the bronchoscope. First with an oxygen source, second with a lignocaine spray for the spray as you go technique. In this, we would be spraying the local anesthesia in the airway as the bronchoscope would be passing through, and thirdly to a suction port. Now comes the main event. The video to the left shows the maneuver on the patient and the one on the right shows the bronchoscopic view. After giving minimal dose of fentanyl, first the scope was passed nasally, but the narrowed passage made it difficult to visualize the airway, thus increasing the chance of bleeding. So this approach was aborted. Oral approach was then taken. The scope was advanced slowly, spraying the local anesthesia as we advanced further. Amidst all the distorted tissues, narrowed passages, the normal airway finally started to reveal itself. The vocal cords were seen shining and our hopes were high. The preloaded ET tube was then passed through the vocal cords. And then finally, the good things which our eyes wanted to see, the EtCO2, and our ears wanted to hear, the bilateral air entry. It was reconfirmed by a check bronchoscopy in which the bronchoscope was again passed through the ET tube, going down through the tube, and there we were able to visualize the carina and were very certain that we were in the trachea. Post-intubation chest X-ray also confirmed our finding. And for the first time, the patient and the whole emergency room was able to breathe normally again. Post-intubation, the patient's saturation improved to 100% on 25% FiO2 on volume control mode, and these are the before and after images of the patient. The patient withstood the procedure very comfortably, having no distress. At disposition, the patient stabilized, mechanical ventilation was removed, he maintained saturation on minimal oxygen support and was admitted under the Department of Surgical Oncology. No active management of the disease was advised, but a plan for tracheostomy was proposed, but for which the patient and his attendants refused and took discharge the next day. Cases like these are fortunately rare in the emergency department, and because they are rare, they become important. And so is the limited literature on awake intubation in the emergency department. In a large airway registry constituting nearly 20,000 patients, awake intubation was done in only 0.4% of the patients, and the most common indication being angioedema. In another case reported in December 2025, a case similar to ours in which a patient with a prior head and neck cancer surgery presenting with severe hypoxemic respiratory failure and marked limited mouth opening, in which the conventional laryngoscopy and video laryngoscopy were predicted to fail, awake fiber optic intubation was done successfully. And this is where our department story becomes important. In a study conducted from April 2024 to October 2025, 165 patients were enrolled, of which 36% of the patients had a difficult airway. Other metrics from our study showed high first pass success, strong RSI practices, and high bougie utilization, leading to low major adverse events. These numbers are comparable and even better than the Indian and the global averages. These numbers are not just statistics. They represent preparation, training, and teamwork. And honestly, the success with these numbers and even today's case not just belongs to the procedure, but to the people behind it. Under the guidance of our HOD, Dr. Suchita ma'am, our department has developed a culture where difficult airways are dealt with preparation, strategy, and calm decision making. And because of that teaching, there has been no death in emergency due to inability to secure an airway. To give you a sneak peek into the kind of difficult airways which we routinely encounter in the department, ranging from medical emergencies like anaphylaxis to electrocution, to gruesome neck trauma where the trachea is literally exposed to the outside world, and to even rare and surreal challenges of bear attack. The various techniques which we use, which we have at our disposal are the video laryngoscopy, cricothyrotomy, and some novel techniques like video-assisted fiber optic intubation. In the end, I would like to thank the management for continuously strengthening the emergency department with the state-of-the-art infrastructure, the CCR review committee for providing their valuable insight, Department of Anatomy for reminding us to stay humble and not forgetting the basics, patients and his relatives, so the supporting staff, technicians on duty, and lastly, but not the least, the audience for their patience. And since it is Emergency Medicine Day today, the theme being advocacy for protection against the violence, we hope the violence against doctors becomes less. In that hope, we remain very hopeful. So thank you so much. Happy Emergency Medicine Day.